gastroesophageal reflux. And I put in parenthesis the D for GER disease, which is the treatable form of reflux. Historically, if we look over the last, I guess, 50 years, this is probably the most overtreated problem that we have in pediatric gastroenterology. So what I'm going to try to do today is give you a little bit of the history, discuss an approach. There'll be opinion, and I urge Dr. Levine and Dr. Rabinowitz to chime in because we all have our opinions about the management of reflux. So let's see how we start. So first of all, let's look at some definitions. Gastroesophageal reflux is defined as the passage of gastric contents into the esophagus. When we add the D to it, or gastroesophageal reflux disease, this defines a condition where the symptoms or complications that occur as a result of gastric contents refluxing into the esophagus or oropharynx. Now, again, semantics are important. Regurgitation is passage of reflux gastric contents into the oropharynx, and vomiting, obviously, is the expulsion from the mouth. So those are the basic definitions that we're going to be considering. So what are the pathogenic factors that lead to gastroesophageal reflux disease? Well, first of all, what is the mechanisms of reflux? Again, when Dr. Rabinowitz and I were early in training, we told the lower esophageal sphincter is weak. Well, it's not weak, but during the developmental process, postnatally, the lower esophageal sphincter undergoes what are termed transient relaxations. These occur in everybody every day. The most common time that these occur is when we're sleeping at night in the prone or supine position. But these also can occur when the stomach is full. When we have a transient LES relaxation and the stomach is full, that obviously increases the likelihood of having reflux. Any increase in intra-abdominal pressure. So examples, if you are obese, does that increase the likelihood of you having reflux? There are studies that basically confirm or deny that situation. If you have a shortened esophagus, you may have reduced esophageal capacitance. What is your gastric compliance? And we also know that individuals who have reflux tend to have delayed gastric emptying. Again, are these problems that occur together? Well, I would think they would be, because both emptying from the stomach and emptying from the esophagus are controlled by sphincteric structures, the lower esophageal sphincter, the pyloric sphincter. And of course, as we know, all sphincters respond to relaxation secondary to the elaboration of nitric oxide. So it's not surprising that delayed gastric emptying may go along with gastroesophageal reflux. So what are the mechanisms of esophageal complications? Well, the esophagus is normally quite resistant to acid. However, if you have a condition where you have impaired esophageal clearance or some noxious factor that results in defective tissue resistance, again, the refluxate being highly acid, if it stays in the esophagus for a long period of time, despite the fact that the esophagus is relatively resistant, you can have damage. And then secondary to reflux, you also may have airway complications. And this may result from impaired airway protection with an abnormal gag mechanism. We see this commonly in patients who are neurodivergent. And of course, then this reflux can lead to the stimulation of vagal reflexes, which can also affect the pulmonary bed. The anti-reflux barrier is key, and it comprises a number of structures and anatomic relationships. The lower esophageal sphincter, as you can see, the LES begins at the level of the diaphragm and extends into the intra-abdominal region. There is a defined angle by which the esophagus enters into the stomach. This is called the angle of His. Any deviation from the normal angle can again increase your likelihood of developing reflux. And also the diaphragm itself. So one might imagine in a subject with reactive airway disease, the diaphragm may be pushed down, and so the LES may become a intrathoracic structure, more prone to negative pressure, keeping it open. By the same token, it can be pushed up also in someone who is obese, again, elevating the LES above the level of the diaphragm. As I mentioned, transient lower esophageal relaxations occur normally, and it's shown here. This is a typical esophageal pH study. You should all be familiar with this. This is on top, the pH. Okay, the pH in the esophagus is normally slightly acid and then can dip during periods of reflux. And these are swallows. And as you can see, with a swallowing mechanism, you have a relaxation down here of the LES. But here you have another relaxation of the LES. And here is one here occurring before the swallow. And when it occurs before the swallow, this is called a transient lower esophageal sphincter relaxation. And at that time, you can see how the pH drops in the esophagus. So these transient LES relaxations are associated with the passage of gastric acid into the esophagus. Infants have a shorter esophagus with a smaller capacity, which is one of the reasons that they are more prone to having gastroesophageal reflux. The other thing to note is that despite the fact that all babies should be back to sleep, in a baby with reflux, that is not the best position, because as you can see here, the esophagus tends to enter the stomach in a posterior location. And so when the stomach is full, the level of the LES is below the level of the fluid. If you turn the infant prone after feeding, then you can see the LES will be on top and the fluid level will be below it, reducing the likelihood of reflux. So one of the things that I always tell families with an infant with reflux is put the baby in a prone position for 30 minutes after feeding under direct observation, of course, and then after 30 to 45 minutes, flip the baby back to sleep. That 30 to 45 minutes leaves enough time for the stomach to empty so that the baby can safely be put back to sleep. One of the earliest and most extensive evaluators of reflux in infants was Dr. Suzanne Nelson, who published a number of articles. They're quite old, but still quite relevant. And one of the things that Dr. Nelson looked at was the epidemiology of infant reflux. As shown here, the percent of infants is on the y-axis and the age in months on the x-axis. The yellow bars showed the number of times the infant vomited more than once a day, the blue more than 4 times a day, and the pink is a problem. And as you can see here, it most became a problem at age 4 to 6 months. So when expectant care is the best kind of care that you can provide to your patients. And so when I see a newborn or 2 or 3 month old infant with reflux who's otherwise growing and developing normally, I generally tell the parents, listen, this is probably going to get worse over the next couple of months, but it should not affect your child's growth and development. And then after 6 months, as you can see by the 2 remaining categories, 7 to 9 and 10 to 12 months, there's a marked improvement in reflux. So this is the physiological progression of reflux during infancy. It has an increase for the first 4 to 6 months, followed by a decrease, so that in the vast majority of infants, by 10 to 12 months of age is no longer a problem. When we have a baby who presents with the symptoms of reflux, we always want to look for warning signals that are suggestive of a non-reflux diagnosis. So, infant presents with recurrent vomiting, you do a history and physical examination. And here are a list of problems that you want to be aware of. Obviously, bilious vomiting is never normal. Forceful vomiting, well, again, forceful vomiting is very subjective. Forceful vomiting can occur in reflux. Of course, it can also occur in infection, septicemia, or, of course, anatomically in an infant with pyloric stenosis. The presence of blood in the vomitus, the failure to grow normally, associated GI symptoms, any positive physical finding. The infant who starts to have vomiting after 6 months of age has to be carefully evaluated for other causes, because reflux as an infantile problem does not occur at 6 months, does not initiate after 6 months of age. Is there an atopic history, which might suggest something like cow milk protein allergy? Any other signs or symptoms? Of course, anyone with increased intracranial pressure can experience vomiting. And so these are all the things that you need to be aware of when a child presents to you. Are there these warning signals? If there are, then obviously further workup is indicated. What about signs of GERD in the absence of associated system difficulties? Growth failure. Does the child appear to be in pain, or is there feeding-associated irritability? Does the child refuse to feed? Obviously, if they associate feeding with pain, feeding refusal becomes a problem. Obviously, blood, the passage of anemia. One of the things that we're going to be talking about, and again, Dr. Rabinowitz and I, in training, I can't count the number of times I was asked to see a child who presented with an apparent life-threatening event or an apneaing event. Could this be reflux? And we'll go over that data. What about respiratory symptoms? What about pneumonias? What about upper airway symptoms? Suffice it to say that those children who are most prone to develop respiratory problems related to reflux are going to be those kids who have some problems with gag reflex or airway protection. And again, I go back to the neurodivergent population. So again, in the absence of these possible signs of GERD, we're dealing with essentially uncomplicated gastroesophageal reflux. Here's a quote: based upon expert opinion, a history and physical examination with attention to warning signals suggestive of other diagnoses is generally sufficient to establish a diagnosis of uncomplicated infant GER. Again, if there are no associated symptoms, the child is otherwise growing well. A child with emesis without any of these warning signals can be assumed to have uncomplicated infant GER.
Of interest is the fact that the American College of Gastroenterology established exactly the same wording for adults.
You just faded out, Simon. I don't think everybody heard you.
I apologize for my...
Yeah, I can hardly hear you.
And just skip it. You heard it, you heard it.
All right, okay, fine. Well, I didn't. All right, anywhere. How do you manage uncomplicated reflux? You reassure, you educate, and as I mentioned, you provide anticipatory guidance. You may want to modify the feeding frequency or volume. Volume is easy to do in a bottle-fed infant. In a breastfed infant, you may want to you may want to decrease the feeding frequency, which by itself is going to decrease the feeding volume. And then, as I mentioned earlier, a prone or left lateral positioning for a limited amount of time under observation can be attempted. In those infants in whom you may suspect a problem with cow milk allergy, and again, this is going to be highly subjective, a 2-week trial of an elemental or amino acid-based formula may be tried to rule out cow's milk protein allergy. Consider thickened feedings or a commercial anti-reflux formula. If you're going to thicken the feedings, remember, we're not going to use rice these days anymore because of the problems with arsenic. You may want to thicken with oatmeal, for example. But again, you're not going to do this in any infant under 2 months of age because of the problem of possible starch maldigestion. And I think the most important thing is for physiological infant GER, pharmacologic therapy is of no benefit. So again, I'm also going to keep telling you stuff that I've told you. The symptoms and signs of GER disease change with age. In the infant, we've already gone over those things. In the older child or adolescent, recurrent regurgitation, hemodemesis, heartburn. Again, heartburn is a very reliable symptom related to the passage of acid into the esophagus. Abdominal pain, dysphagia or odynophagia is a sign of possible GER disease. And again, is there any evidence for any either upper airway or lower airway complication? In adults, GERD is based upon the patient's description of bothersome symptoms. Again, heartburn is the most reliable. If you have an older child who presents with a history of regurgitation and heartburn, well, the cause is generally gastroesophageal reflux. And so empiric therapy in those situations is certainly a possibility. So again, if you're diagnosing infant GERD, that may or may not be so easy. And so you want to know whether symptoms such as irritability, crying, fussing, stopping of feeding, spitting up, feeding refusal, or back arching are reliable symptoms that might warrant further therapy. Well, the causes of infant irritability are legion, and some of them are shown here. I think I'm not going to go over these, but obviously anything that affects the normal situation in a growing infant can result in irritability. In fact, in normal infants, and this has been studied, again, an older study, if you look at the total minutes of crying per day in normal infants, it's 2 hours a day for 1 to 3 months, an hour a day from 4 to 6, 72 from 7 to 9, and again, almost an hour in the 10 to 12-month-old. But look at the standard deviations. They're huge. So the total minutes of infant crying per day in normal infants can be very significant. And of course, an infant who cries for 2 minutes, the parents think it's 20 minutes. And an infant who cries for 20 minutes, the parents often say it's over 2 hours. So sometimes putting a stopwatch on it may be a good idea to find out if the child is well outside the norm. So, does this reflect a normal situation? Does it reflect reflux, or is something else going on? So symptoms including regurgitation, colic, irritability, and vomiting are common among otherwise normal infants. And furthermore, we also know that symptoms of GER may be indistinguishable from those of food allergy. So this may be a difficult problem in which which to evaluate. So let's look at the duration of crying in relationship to the appearance of pathological gastroesophageal reflux. All right. Duration of crying here is shown on the y-axis. Fractional reflux time is shown on the x-axis. And as you can see, this is not significant. You cannot correlate the duration of crying time as being indicative of the fractional reflux time. The only predictors in this study of pathological GER were regurgitation and feeding difficulties or feeding refusal, not the duration of crying. Put together in infants and toddlers, there are no symptoms or group of symptoms that can reliably diagnose GERD or predict treatment response. That presents the pediatric gastroenterologist and the pediatrician with a problem. Who do we evaluate? Who do we treat? Well, what about a trial of empiric proton pump inhibitor therapy? Does that make sense in an irritable infant? So this is a study looking at infant irritability and omeprazole therapy. It's a double-blind, placebo-controlled crossover trial in 64 infants with microscopic esophagitis or a positive esophageal pH study. Age 3 to 12 months, the treatment group decreased the reflux index from 9.9 to 1%. Obviously, if you get rid of acid, the reflux time is going to decrease because the esophageal pH will remain neutral. The crying and fussing time increased in both groups over 4 weeks. So both in the placebo and in the treatment group, crying and fussing time decreased from 270 to about 190 minutes per 24 hours. There was no difference between the treatment and the placebo groups. So here we have a double-blind placebo-controlled trial with a PPI treatment for 4 weeks. Subject, the infants were 28 days to 12 months, diagnosed with GERD based on a symptom-based questionnaire of typical reflux symptoms: spitting up, crying, fussing, irritability, stopping feeding, feeding refusal, and back arching. All the things we talked about before. So let's look at the two groups. One is on lansoprazole, you see the middle column, and then placebo on the right column. Crying, fussing, and irritability, no change. Spitting up or vomiting, no change. Stopping feeding after starting, no change. Arching of back, no change. Feeding refusal, no change. The number of adverse events, this was also not significant, but look at the trend. The number of adverse events was more common in those infants on lansoprazole compared to those on placebo, and most of these were respiratory. Why do you suppose that might happen? Well, one of the theories is that, again, what is the barrier to bacterial entry into our bodies? Acid. You get rid of the acid, you create a scenario where bacterial translocation will become more likely. And further studies have proven this. Patients on long-term PPI therapy may be more prone to developing respiratory infections. Feeding refusal. Here are 20 infants, aged 5 to 6. Acid exposure on 24-hour pH monitoring. They were evaluated for feeding issues while on therapy. Infants with GER were more likely to report swallowing problems, vomiting, and respiratory symptoms. Infants with GER had lower energy intakes than controls, despite being on therapy. Remember, this is on therapy. So 16 to 20 of these infants were judged to have moderate to severe oral motor dysfunction. 80% of control infants, but only 16% of GERD infants could hold a spoon with feedings. Infants with GERD are more likely to have developmental delays or be neurodivergent that causes feeding difficulties. So this is one of the early studies that was done to confirm the work that, of course, Dr. Rabinowitz and I were engaged in for some time, looking at the management of children who are neurodivergent with severe developmental issues. These are the most high-risk infants for developing problems related to acid itself. And of course, this includes not only gastroesophageal reflux, but also includes those infants who have oromotor dysfunction and have problems with airway protection. I've already mentioned some of the side effects of PPI therapy. There are many of them. The most important, of course, being the increased risk of community-acquired pneumonia and acute GI-itis in children and adults with PPI. And of course, by the same token, acid is a potent inhibitor of bacterial and fungal growth. So in premature infants treated with acid-reducing therapy, there was an increased risk of candidemia and necrotizing enterocolitis. Well, despite all this, pediatricians for many, many years, and probably still do, used PPI in those infants with uncomplicated reflux. So this is a study that looked at 1 million infant records from 4 major U.S. health plans. Of those 1 million infants, 5,000 or 0.5% received a PPI during the first year of life, half of them before age of 4 months. Prescribing indications were crying or colic, 22%, feeding problems, 23%, respiratory problems with presumed allergy, 32%, gastroesophageal reflux, 60%, and 21% esophagitis based upon biopsy evidence. So for the first 4 categories, none of them documented, in fact, that reflux was the problem at all. It was all based upon the symptom of regurgitation. Only the final category, 21%, was based on hard evidence. Only 10% of them underwent any diagnostic testing. So even in the esophagitis group, of that group, half of them had no diagnostic testing. So, available evidence does not support empiric acid suppressive therapy for treatment of infants with irritability. Consider a trial of a hydrolyzed formula. If symptoms persist and other symptoms are observed, an upper endoscopy to rule out esophagitis may be indicated. Esophageal impedance and pH monitoring may document symptom association with episodes of GER, but may not. And if these studies are negative, GER should not be considered as a potential cause of the infant symptoms. So who undergoes pH monitoring? These days, there really are very few infants who really will require pH monitoring. We would pretty much stop at endoscopy in terms of the evaluation. And we'll talk about the value or lack of value of imaging studies. How do we evaluate infants and children with feeding difficulties or problems with swallowing or reflux? A careful history and physical examination, a clinical observation of symptoms during feeding, a radiographic contrast study may be indicated. The video fluoroscopic swallowing study is especially useful because it helps to rule out swallowing or oromotor dysfunction. And if no other etiology is found, an endoscopy with biopsy. Empiric therapy is not recommended in otherwise normal children, except in older children able to report symptoms of typical GERD, heartburn being the most common. So, history and physical examination. Are there warning signals? Evaluate further. Is the calorie intake adequate? Work them up if the calorie intake is adequate, then education and closer follow-up. This should be no. If the adequate calorie intake is not adequate, if the calorie intake is not adequate, then you're going to work them up further. What if you do an upper GI series or a video fluoroscopic swallowing study? Is it abnormal? If it's yes, manage accordingly. If it's not abnormal, dietary management, consider a protein hydrolysate formula, thicken feedings, increase calorie density. If it's improved, education and close follow-up. If not, then consultation with pediatric GI. So this is really guidance for the pediatrician. So hopefully we would be seeing patients all the way at the bottom. In fact, we generally don't. I imagine that's still true. Infant presents with vomiting, send them to a pediatric gastroenterologist. And then you'll go through all of these things. So, how do we go about the diagnosis of GERD in children and adolescents? If we look at symptom prevalence, these do change with age. The blue bars are 1 to 5 years of age. The purple bars are 6 to 11. The yellow are 12 to 17. And the starred areas are significantly different from the other age groups. So, the percent of patients who present with coughing related to erosive esophagitis is more common in the 1 to 5 year, as well as feeding refusal, more common in the 1 to 5 year. In the later age groups, the only significant difference would be heartburn, which is significantly less common in the 1 to 5 year age. You can see that all the way to the right. And the reason for that is quite simple. A child under 5 years of age may not be able to localize pain. Because they can't localize pain, they can't tell you where it hurts. So, but overall, you see that this constellation of symptoms can occur at any age group. There are, of course, symptoms that overlap with those of GERD. These are shown here. I'm not going to go over all of them, but of course, Dr. Rabinowitz will be talking to you all about eosinophilic esophagitis, which now comprises, if not the most common reason we see, pathological reason we see children with esophageal problems, it's close to it now. Of course, when we were in training, we didn't know what eosinophilic esophagitis was. So we can't look back on it and say it's more common. It's just that we're able to diagnose it now. So the combined European and North American societies for pediatric gastroenterology state that in infants and toddlers, there are no symptoms or group of symptoms that can reliably diagnose GERD or predict treatment response. In older children and adolescents, a history and PE are generally sufficient to reliably diagnose GERD and initiate management. So these children present with GERD in an older child, heartburn, regurgitation, PPI for 1 to 2 months, symptoms persist, endoscopy, symptoms resolve, observe them, and then if the symptoms recur, endoscopy and biopsy. That's generally what we will do. In younger children, the symptom-based diagnosis is unreliable, and so further evaluation, including a pH probe analysis and or endoscopy, may be indicated. Again, in younger children, as I showed you in the earlier slides, the response to therapy is not diagnostic of GERD. Well, if symptom reports are unreliable for the diagnosis of GERD in children, how do we diagnose it? So here's a little endoscopy quiz for you. Well, not a quiz because the answer is here. The one word I never want to hear when someone does an endoscopy is erythema. Beauty is in the eye of the beholder. Our cameras are set differently. The presence of erythema without obvious mucosal breaks should be considered normal. And the description of erythema is highly variable from investigator to investigator, from endoscopist to endoscopist. However, if you see erosions or mucosal breaks, there is good inter-observer reliability, and those are considered highly indicative of acid-related injury. Erythema is normal. The esophageal mucosal lesions of gastroesophageal reflux, of course, have to be differentiated from other causes, not only acid, right? They're shown here, including Barrett's esophagus, EOE, infections, Crohn's, Mallory-Weiss tears from forceful vomiting, all right, on a wide variety of disorders. Now, of course, in each patient, we're going to know what their baseline situation is. So we're not going to consider all of these diagnoses in every patient. But it's important to note that there can be numerous causes of esophageal mucosal lesions in children. How do we manage them? If we see erosive esophagitis, we put the patient on a PPI, obviously, and after a few months, we can continue therapy if we suspect a chronic or relapsing disease. In some patients, we can discontinue therapy. In many, we can discontinue therapy and it doesn't come back. But if there are persistent lesions, despite being on a PPI, do we increase the PPI dose? Do we send this child for a Nissen fundoplication? Do we consider other diagnoses? Now, what about surgery? What about the Nissen fundoplication? I will tell you now, in my, 45 years of clinical practice, I sent one child to have a Nissen fundoplication who was not neurodivergent. I sent many children for fundoplications, but these were invariably children with severe developmental issues, where one could predict that reflux would be unremitting and unresolving. But in otherwise normal children, the progression to surgery is an extremely uncommon event. So is erosive esophagitis recurring, a chronic relapsing disease, or can you treat it and have it go away? So this is a study where omeprazole was given and patients were treated for 3 months. Of the 48 patients that were treated, 46 were healed. They either went on omeprazole or ranitidine or placebo, and there was relapse in only one patient with erosions at 12 months after initial therapy, and in 3 of 44, 7%, there were mild symptoms within 30 months. So in this study, in the vast majority of infants, a single course of therapy lasting 3 months, followed by lower dose therapy, resulted in only mild symptoms, and this included those who were on placebo. The low rate of relapse, even without maintenance treatment, suggests that there may be different pathophysiological pathways involved in the mechanism of GERD in children, and so that not all reflux esophagitis in children is chronic and relapsing. So this is in 2008, still true today. We treat these children with erosive esophagitis for 3 to 6 months. If they're healed or symptoms resolved, observe and retreat only with symptom recurrence. If symptoms persist, you may want to repeat the endoscopy and may want to consider other diagnostic entities. Or, of course, the problem of noncompliance with medical therapy must also be considered. So what about non-erosive reflux disease? Someone can have symptoms related to reflux, but not have any endoscopic evidence of disease. So can a biopsy be used for the diagnosis of GERD in patients with non-erosive disease? Is it sensitive and specific? So there's a poor correlation among all parameters of inflammation on esophageal histology and symptoms, endoscopic findings, or pH monitoring, both qualitatively and quantitatively in children. So we all talk about less than 15 eosinophils per high power field. That's reflux. More than 15 eosinophils per high power field. That's EOE. I will ask at some point when he gives his EOE lecture, Dr. Rabinowitz to comment on this, because I've often wondered why that is a magic number, that a patient with EOE can't have less than 15 and a patient with reflux can't have more than 15. So we've obviously developed PPI responsive esophageal eosinophilia to deal with those patients who were not sure what camp they fall into. Reflux-induced esophageal damage is defined endoscopically as visible breaks of the distal esophageal mucosa. We've already discussed that. Endoscopic biopsy cannot determine whether esophagitis, if present, is due to reflux. That is also true. The absence of histologic changes does not rule out reflux disease. Upper GI radiography is useful only for detecting anatomic abnormalities. It cannot discriminate between physiologic and non-physiological reflux. Do not use an upper GI to diagnose reflux. Use an upper GI to identify possible anatomic abnormalities. Scintigraphy, a study we all like to order, which I found to be virtually useless. Theoretically, it can detect acidic and non-acidic GER. It does evaluate gastric emptying. It may demonstrate aspiration. There's lack of standardization. There's absence of age-specific normative data. And the period of observation is generally limited to the early postprandial period. When I ordered it, I always ordered it because I was concerned about aspiration and respiratory compromise. So I would order the study. I would order it to be followed 1 hour after the radioactive material is ingested. And then I would always have the patient come back the next day to be scanned to see if any of this material appeared in the pulmonary bed. Esophageal pH monitoring, a study we virtually don't do anymore. This happens to be one of the patients that my group when we were at New York Medical College reported it was the first use of this ambulatory pH monitoring. So esophageal pH monitoring can detect episodes of reflux. It can determine a temporal association between acid, GER, and symptoms, determine the effectiveness of esophageal clearance, and assess the adequacy of H2RA or PPI. It can't detect non-acidic reflux, can't detect complications, and not useful for detecting the association between GER and other respiratory problems. So, what is physiological reflux? Well, infants, children, and adults, if you look at the number of daily reflux episodes, they're very high in infants, decrease, and increase slightly in adulthood. The number of reflux episodes greater than 5 minutes is greater in infants, much lower in adults. Remember, we talked about the transit esophageal relaxations. And the reflux index, the percent of time, pH less than 4, 12% in infants, and then 5 to 6% in children and adults. So we have, ever since this study came out, we have used that 6% level as being the maximum time of pH less than 4 in the esophagus during a 24-hour period. Multiple intraluminal electric impedance measurements. We don't do it here. You should look it up. It detects non-acidic GER episodes, detects brief GER episodes, and it's useful for studying respiratory symptoms and GER in infants. And really, as we know, an electrical current will pass quicker through liquid than it will through air. So when you have a drop in impedance, and here you see the drop in impedance, all right, this is associated with liquid being in the esophagus, not necessarily acid liquid, but liquid in the esophagus. So this can identify the passage of gastric contents of whatever pH into the esophagus. So the pH plus impedance has advantages in that it can detect non-acid reflux. It can also give you the height of the refluxate and also can look at clearance from the esophagus. So when it's done, and most of this now is done at investigational centers, the combined usage of impedance and pH recording is superior to pH monitoring alone for the evaluation of GEA-related symptom association. But again, this would only be used in a very defined group of infants and children. And again, I go back to the population. So let's look at the approach to the child with symptoms of gastroesophageal reflux. Again, empiric therapy, symptoms resolved, wean and observe, symptoms recur, that goes to endoscopy and biopsy. Same if symptoms persist. And then endoscopy and biopsy, normal mucosa with a normal biopsy. Again, that's possible, GERD, even though there is no evidence of a pathological break in the mucosa. If there's erosive esophagitis, that is clearly consistent with GERD. If there's a normal mucosa and abnormal biopsy, that's possible GERD. Whenever you have a normal mucosa, even with an abnormal biopsy, that is the time to consider further testing or to correlate symptoms or to assure adequate treatment and consider other diagnoses. So we're going to stop in a few minutes, but I'd like to go over first the whole problem of respiratory problems related to reflux. This was an early study which prompted other studies, several of which I published with my group that I now regret publishing. Because in this study done by John Herbst a long time ago, GER was associated with the episodes of obstructive or mixed apnea. So here was looked at is chest wall movement, nasal airflow, how much air is going in and out, all right? When you have a reflux episode, when you have an apneic episode, chest wall movement becomes irregular, nasal airflow becomes irregular or absent, and here we have esophageal pH going from 6 down to 2, chest wall movement becomes irregular, and an absence of nasal airflow. So here, there's a clear association between the two. However, further studies have shown that there's no convincing temporal association of GER and central apnea or bradycardia. Apparent life-threatening events can be caused by cardiac disorders, CNS disease, infectious disorders, airway obstruction, or suffocation, obviously. So GER should not be assumed as the cause of ALTI. No studies have demonstrated the effectiveness of treating GER in reducing obstructive apneic episodes, as I showed you on the previous slide. And Infants generally outgrow these episodes, and surgical treatment is rarely required. GER-related pneumonia is rare in otherwise normal children, and you need to rule out other causes. And I make the caveat that it's rare in otherwise normal children. It is not rare in the severely neurodivergent population, who are quite prone to developing aspiration pneumonia related to both swallowing dysfunction and gastroesophageal reflux. GER-related aspiration pneumonia, again, may arise in the absence of esophagitis. Normal esophageal pH monitoring does not exclude GER as a cause of aspiration pneumonia. Remember, these neurodivergent children may have problems with airway protection and their gag reflex, so they may have physiological reflux resulting in aspiration. So a combination of tests may aid in the diagnosis, but none have been proven to be diagnostic of GEA-related recurrent pneumonia. And we've used bronchoalveolar lavage, looking for lipid-related macrophages, scintigraphy, video fluoroscopic swallowing study, which I think is very important to rule out oromotor dysfunction. And then, of course, esophageal impedance or endoscopy. In those children who are neurodivergent, one, of course, wonders whether PPI treatment will prevent pneumonia. So this is a multi-center study of 69 children that underwent endoscopy. All had esophagitis, and they were treated with omeprazole. If they look at the PPI treatment of GER and neurodevelopment delay, the blue bar is before PPI therapy, the yellow is after PPI therapy, and in this group of patients, PPIs were quite beneficial in reducing the likelihood of developing respiratory problems. So we don't need to do double-blind placebo-controlled trials in normal and neurologically abnormal children. If you have a neurodivergent child who presents with symptoms related to reflux and respiratory compromise, empiric therapy with a PPI is certainly advisable. And what about surgery? This was the study that looked at the database from Washington State. It measured hospitalizations for reflux-related respiratory events before and after anti-reflux surgery. And this is between 1987 and 2001. 1,100 patients had anti-reflux surgery. 52% had respiratory events prior to surgery. Among the children with surgery during the first year of life, the problems decreased from 1.95 to 0.67 per year. Among children 1 to 3 years, reflux-related hospital admissions decreased. Among children 4 to 18 years of age, reflux-related hospitalization did not decline. The developmental delay was significantly associated with higher postoperative rates of recurrent hospital admissions, but only in patients that had reflux surgery at ages greater than 4 years of age. So, what does that tell you? It tells you in those patients who are neurodivergent, if you operate on them greater than 4 years of age, they may have already established a fixed respiratory compromise that will continue to be prone to the development of respiratory events. So as a clinician, you have to make management decisions. And there's really a dearth of information, certainly in normal children, about the response to invasive treatment. The potential benefits of surgery must be balanced with possible complications, and there are no controlled studies that demonstrate the benefits of any medical therapy pre and post surgery. What about children with asthma? Symptoms of GER are common in children with asthma. As I showed you earlier, because of the downward deflection of the diaphragm. In a compilation of 13 case series, 61% of children had GER. Of these, about 50% had no or minimal symptoms. And this is a double-blind placebo-controlled trial in 770 adults using esomeprazole or placebo. There was no statistically significant improvement in the primary endpoints of peak expiratory flow in treatment versus placebo. And again, does treatment with PPI improve asthma in adults? Well, really only in those over to the right that have nocturnal symptoms. If you have a child, an older child who presents with nocturnal symptoms, nocturnal respiratory symptoms, who has a history consistent with gastroesophageal reflux, that is the one group that may benefit from PPI therapy. Only the ones with nocturnal symptoms and with symptoms suggestive of GER. So here we see the change in FEV1, and the subgroup analysis showed that treatment decreased forced expiratory volume 1 only in patients with GER and nocturnal asthma symptoms. So here's a study looking at improved asthma symptoms in children. pH studies were performed. 45 children had a reflux index greater than 5%, 18 on omeprazole, 18 on placebo. No difference in symptom scores, no difference in lung functions. Surveys suggested some improvement in quality of life, but that may have been related to any one of a number of factors. So in patients with GER symptoms and moderate to severe asthma, a trial of PPI therapy is reasonable, but efficacy may only be expected in patients with nocturnal symptoms. Previous guidelines recommended pH probe to guide treatment decisions, but evidence is lacking to support this recommendation. If treatment is initiated, outcome variables such as symptoms, medication use, and pulmonary function changes should be monitored, and the role of medical and surgical GERD therapy in this patient group remains poorly defined. What about laryngeal? I'm going to stop with laryngeal. Actually, I think I should stop here and pick up on Wednesday because I got probably about 40 slides left to go. I'm going to stop sharing my screen